We have a guest in the studio. He's Dr. Anthony Etyang, who is the head of epidemiology and demography at the KEMRI Wellcome Trust Research Program. We'll be talking about improving hypertension control in rural sub-Saharan Africa. We welcome him with the day's proverb.
Yes, our proverbs for the whole of this week come from the country of Zambia. Take care of the neck. Necklaces are not difficult to find.
Take care of the neck. Necklaces are not difficult to find. Dr. Etyang, good morning.
Good morning.
Welcome to Kenya's biggest conversation.
Thank you very much.
The hot seat of the Situation Room. Let's begin with that proverb. What's your interpretation of it?
Well, a very interesting proverb. My interpretation, I think it's advising you to take care of what you can't replace. Yeah, there are many things that can be replaced, but others, like what we're going to talk about today with regard to health, you can't really replace them. So take care of your neck. You can replace necklaces, but you can't replace your neck if you lose it.
Very well said, eh?
Unless you're a lizard.
Sindio?
Sorry.
I've got a couple of Zambian friends, so maybe I've misinterpreted it. I'll find out from them.
They'll tell you that is not what they meant. But it makes sense what you're saying. I mean, that interpretation makes a lot of sense. Doc, you here, so we can talk about improving hypertension control in rural sub-Saharan Africa. Let's first of all start by completely defining and understanding what is hypertension.
All right. Thank you very much. So, that's a very relevant question. So, there's a concept known as blood pressure, and blood pressure is the force with which blood moves within the arteries or blood vessels in your body. Now, there's a normal range of pressure, just like we've been talking about water in Vipingo and other places. So, there's a normal amount of force that blood moves within those blood vessels. If that force, that pressure goes above a certain threshold, and people discuss what the proper threshold should be, if it goes above a certain threshold, then you call it hypertension. Yes, so it's above a certain threshold. Most people use 140 millimeters of mercury as the threshold. Some people use 130/80, but the main thing is that it's above the normal limit. And when it's above that normal limit, then you're at increased risk of getting diseases such as strokes, heart attacks, kidney disease, and things like that. Yep.
Can it be interchangeable with high blood pressure?
Yes, it is interchangeable. Yeah, so in loose talk, yes, you can call high blood pressure and hypertension are essentially the same thing. Yes, the definitions, scientists as usual disagree a bit on what the cutoff is. But
why do they disagree?
So it's the main thing is you want to create a threshold above which you say you must treat, and the agreement on when you must treat is based on what benefits you'll get as a result of the treatment. As opposed to some of the trade-offs, and the trade-offs of treatment are there's cost, there's side effects. So the benefits of treatment are in terms of preventing someone from getting a heart attack, from getting a stroke, from getting kidney disease. It's not completely agreed at what threshold do you suddenly become at higher risk of getting those diseases, and therefore you need to treat, taking into account the costs and the side effects of treatment.
You know, when you mentioned the heart,
Yes.
I'm taken to the biology classes when I was in secondary school. And if those fellows taught me right, they mentioned that the heart pumps blood. Essentially, its job is to pump. So this speed that we are speaking of, what's the relationship between the pump and the blood and the speed at which this blood moves in the body?
And the size of the pipe.
Yes.
Yes. No, we will get that size of the pipe and whether that pipe is a constant or sometimes it's not constant and sometimes maybe it requires cleaning. And,
Exactly. You have all the concepts right. So the heart is a pump. And it pumps blood, this fluid, into the vessels within the body so that the blood can go and nourish the various organs of the body. Now, there's a relationship between the force with which it pumps and the pressure that is felt within those vessels into which it pumps. So if it pumps too hard, and it can pump too hard in two ways, either pumping too frequently, or with it might not pump that frequently, but with each compression, it's pumping a lot of blood, and that can increase the force that is felt within the vessels. But similarly, if the vessels are too stiff, because these are pipes, so if they're if they're too stiff, then also they increase the pressure that is transmitted onto the organs into which they're feeding the blood. Yeah.
What would make this happen? What would cause them to be too stiff, or what would cause the pump to move too quickly?
Yes. So various factors that lead to that. So they could be stiff. The most common reason they stiffen is age. So, just with the rest of you, there are things you are much more flexible when you are 10 years old as compared to now. Yes, so that loss of flexibility that you're seeing in your joints is also disappearing from your blood vessels. Your blood vessels become stiffer with time. Similarly, if you increase the volume of blood that is present in you, and there are a couple of reasons why the volume would increase. So, for example, if you take a lot of salt, and where salt goes, water follows, so the volume increases, and that increases the pressure. If you keep everything constant and you increase the volume within a fixed space, then the pressure goes up. So those are some of the things that lead to these changes that we see.
Okay, so then we know what some of the causes of hypertension or high blood pressure actually are.
Yes.
So we've also seen in the last few years, especially, that there's been an increased reporting of high blood pressure cases. I know we're looking at rural Kenya today, or rural communities today, but we're able to say that these are the causes of high blood pressure or hypertension in these particular areas. What would you say are some of the areas? Because as I think of it, then you're talking about lifestyle. What would be some of the lifestyle indicators, causes of high blood pressure?
Yeah, so some of the lifestyle causes, things related to lifestyle that could cause increased blood pressure are diet, for example. And a diet, one of the major factors is salt, which I've talked about. Then obesity in general. So there's a very clear relationship between excessive body weight and blood pressure. Lack of exercise, which you could say is also related to obesity, definitely contributes to high blood pressure. And alcohol intake. All these are lifestyle changes, lifestyle factors. But that said, so we talk a lot about these lifestyle factors because those are things that you can change. Those are modifiable things that you can change with a bit of effort. But there are a couple of other factors which are essentially not modifiable. So the good example I've given you is age. You can't. There's nothing you can do about your age. Then we also think from some of the studies that we're doing, some infections that you get, for example, during childhood or as you're growing up, if you get repeated infections and these infections are affecting the blood vessels, the blood vessels could stiffen, and therefore that could cause high blood pressure later in life. Yeah.
Is hypertension more prevalent in some sectors of society? Say, higher income versus low income?
Yes, so there was actually a study that was done, I think in 2015, 2016, where a group of researchers from Kenya, from the University of Nairobi, the African Population Health and Research Center, they measured blood pressure in a sample of Kenyans, a representative sample all over Kenya, about 5,000 people. So they looked at their blood pressure, they also looked at their diet, they looked at their socioeconomic status. So they came up with some very interesting findings. Some of them, there was a relationship, for example, between socioeconomic status and blood pressure. But that wasn't the area where we saw some of the biggest differences. So some of the biggest factors that they saw in that study was diet, for example, and obesity. People who are obese were much more likely to have high blood pressure. The other thing that was a bit counterintuitive was that you'd expect that people in rural areas would have lower blood pressure, less hypertension than those in urban areas, but the numbers were almost the same in terms of the frequency or the prevalence of hypertension when you compare rural and urban areas. And yet we know that the lifestyle in rural areas is very different from the lifestyles in urban areas. So there are probably different sets of factors that are contributing to hypertension in different settings within our country.
Have those been established?
Not yet. They've been hypothesized, but they're still being, we're trying to establish what these factors could be. Yes.
Tell us a little bit about this research. What was the design of this particular research? So, yes.
Okay.
Just walk us through it.
Okay, I can walk you through it. I can start with an analogy, which I hope is familiar with you. You'll forgive me if it's not familiar. You heard about, maybe about a month ago, there was this Kenya Demographic and Health Survey, which had lots of interesting findings. Of course, people talked about what they found interesting in terms of numbers of partners and things like those, but there are also other interesting
those deeper data.
Yes, okay. Yes. So this study followed essentially the same methodology that the Kenya Demographic and Health Survey used. What they did was they went to the Kenya National Bureau of Statistics, who have data from the national censuses that have been conducted, and they've enumerated created what you call enumeration zones around the country. So they've mapped out the country. They know who lives where and what the numbers of homesteads that are there. Then they randomly selected about 5,000 people across the country based on this database that they had.
Why random?
So that you can then extrapolate to the general population. So if you it's impossible. We've got 50 million Kenyans roughly, and it's really hard to do a study where you'll go interview and take blood pressure on these 50 million people. But if you take a random selection that is representative of these 50 million people, then you can, with a high degree of confidence, make extrapolations as to what the situation is within these 50 million people. So if I take you back to the Kenya Demographic Health Survey, they also did just about 5,000 or 10,000 people randomly selected across the country, and therefore they're able to make extrapolations as to the average number of children that a woman has in Kenya over their lifetime and so on. So yeah.
I'm just looking at specific situations within which high blood pressure can come about and stay, or can come about and leave, one of those being pregnancy. Could this be one of the factors that you see in rural communities? Because preeclampsia and things like this?
Yes.
Conditional hypertension then becomes a state. Many say that with the pregnancy it goes, but then there are some cases where it remains.
Exactly. Yes. So pregnancy is a high risk situation where women are actually at a higher risk of getting preeclampsia, which is a hypertensive state, usually resolves by when the pregnancy ends, when the woman gives birth. But these women that do get preeclampsia and eclampsia have clearly been shown that they're at higher risk of now getting what you call chronic or sustained hypertension after that. So there's actually medical recommendations say that if someone has suffered from preeclampsia, they need to be followed up much more closely, so that if they do get chronic hypertension, they should be followed up and appropriate interventions given. That said, some of the women who suffer preeclampsia, it's only that they were discovered to be hypertensive during pregnancy.
Yeah.
They could have been having this hypertension prior to the pregnancy, but because the pregnancy now put them in contact with the health system, they got their blood pressure measured, and then they were discovered to be hypertensive. But just as you said, if they do get preeclampsia, they're at higher risk of sustained hypertension in life.
As is a common practice, and people want to ask a question. Okay, so the joke people say, well, I feel like I'm having a heart attack, right? So how do you know what would be some of the symptoms of hypertension, and that would then force you to actually go and get yourself checked?
Okay, yeah, so that's a big challenge with hypertension specifically. I'm sure you've heard it being referred to as a silent killer. So hypertension by itself, 99% of the time, there are no symptoms. You won't feel it. There are people who will say, they feel a bit of a headache. It could be pressure problems. But 99% of the time, that elevated number, that BP of 140/90 or higher, 99% of the time, you don't feel anything. But then it eats up your organs over time if it's not controlled. So that you then, after a period of maybe 5-10 years of uncontrolled hypertension, you then get a heart attack. All right, and that's when you'll actually get the chest pain or tightness in your chest, or you suddenly get paralyzed on one side because you've gotten a stroke. In some cases, you can get kidney disease and those things. So the consequences of hypertension are the ones that give you the symptoms, but hypertension in itself, 99% of the time, doesn't give a symptom. If you allow me to give another analogy that I hope is again familiar, it's almost like the difference between HIV infection and AIDS. So carrying the virus usually doesn't have any symptoms. Yes, but as it destroys your immunity, you then now you start getting infections, and those infections are the ones that give you AIDS, which, thank God, nowadays because of ARVs we don't see much of it, but the difference between HIV and AIDS is pretty similar to the difference between hypertension in itself and cardiovascular disease, which are the strokes and heart attacks. Yeah.
Is hypertension an issue of concern in Kenya?
It is a major issue of concern in Kenya. We think, again, going back to the study that I mentioned earlier that was done in Kenya, about a third of all adults in Kenya have hypertension. The major concern is that very few of these people know that they have hypertension. Of those that do know that they have hypertension, very few are on medication or interventions to control their hypertension, and an even smaller proportion of these people who are taking those interventions actually have their blood pressure under control. And so we're getting an increasing number of people getting cardiovascular disease like strokes, hypertension, heart attacks, and kidney disease. And the numbers are increasing. So about a half or more of all deaths among adults nowadays are due to non-communicable diseases, and the majority of these non-communicable diseases are cardiovascular disease, which are stroke and heart attacks.
It's a very high number, though.
Yes.
How is it if you compare urban areas in Kenya and rural areas in Kenya?
Yes. So in terms of hypertension, the numbers of people with hypertension, the percentage of people with hypertension in rural areas is roughly the same as the percentage of people in urban areas that have hypertension. The difference is people in urban areas are more likely to be aware that they have hypertension. The numbers are still dismal. If you start with 100 hypertensives in an urban area, Nairobi, Mombasa, Kisumu, only about 24% of them are aware that they do have hypertension, which in itself is dismal. In rural areas, it's just about 10% of people that are aware that they have hypertension. And remember, this is the first step towards having your blood pressure or your hypertension being put under control. So if you're starting with 10% of people who are aware, then the number of people who actually are taking medication and intervening to control their blood pressure becomes even smaller. I think overall around the country, it's less than 3% of all people with hypertension have it under control. And it's worse in rural areas compared to urban areas for a variety of reasons.
8:30. Let's take that break.
This is the Situation Room, the only way to start your day.
Please ask your questions on SpiceFM KE on Twitter, SpiceFM KE on Facebook, or you can also go to our YouTube page and ask the question to Dr. Etyang. He'll respond to the questions. Dr. You said the people who have hypertension, say in the country, there's a higher likelihood of those in urban areas knowing their status than those in rural areas. Why is that so?
Yes. So a couple of possible reasons. One is they've got better access to health facilities, both in terms of distance to these facilities. You've got more facilities available in urban areas, as well as more healthcare workers available in urban areas. The other reason, of course, is financial. So to access healthcare, unfortunately, there's a relationship between your financial status and your ability to access healthcare, and people in urban areas have a better socioeconomic status, so they're more likely to access healthcare and therefore become aware that they do have hypertension. But as I said, the numbers still, it's a comparison of dwarfs. 20% was it 20% aware in urban areas versus 10% in rural areas, so it's bad in both places.
So what does a simple high blood pressure hypertension test look like? What would you do what does it cost anything? Where do you go? How do you find out?
Yeah, so it's a very difficult question to answer. Most people will be familiar with the simple blood pressure measurement method, where you've got a cuff placed usually on your non-dominant arm. If you're right-handed, it would be put on your left arm. So a cuff is tied there, and then it inflates 1 to 3 times and gives you a number. Usually the machine runs on batteries. Previous machines were using mercury, but there were environmental concerns about mercury, so changed to electronic machines. The problem with that measurement, first of all, it's quite convenient. A few minutes and you have your number. But the problem with that measurement is that it's relatively inaccurate. So if I take your blood pressure right now and repeat it 5 minutes later, you can get very different numbers. And now that causes a challenge, because there are other better methods that give you a more accurate measure of what your blood pressure is, but they're not as convenient, and therefore they would be hard to roll out to the millions of people who have never had their blood pressure measured.
Why would it, sorry, before you go to that,
yes,
why would it be so different here and then 5 minutes later?
Because so the body blood pressure changes. It's a very variable thing. So if you're seated right now, and the purpose of the heart pumping blood around the body is to make sure the blood reaches the various organs. So, for example, your brain. Now it's fighting against gravity. So if you stand, then you're at a higher level. Your brain is at a higher level than it was when you're seated. So your heart needs to pump harder. And when it pumps harder so as to make sure blood reaches your brain, which is you've got more gravity it has to fight against, then your blood pressure goes up. Then emotions, how do I put it? So different states of emotion result in different, in your blood pressure changing over time. So that's why if you repeat the measurement over at different time points and at different circumstances, then you do get different measures, which then makes it really hard to determine what your true blood pressure is, if it exists. Yes.
You know, we talk about blood pressure, and the focus has been high blood pressure. Okay. Where there's a high, there has to be a low somewhere. Now, what brings about the low blood pressure, and what are the effects of low blood pressure? Again, biology, which I was taught in the previous century, some around the middle of the previous century, okay? I was also told that this blood has a lot of water in it, and that this water comprises a really huge percentage of what is actually in my body. So I'm taking a layman's view that this water plays an important role also in this process that we're talking about. So if there isn't enough water to give blood the wherewithal it requires
The
to
liquidity.
do it, the liquidity, then I may have a problem. Now explain to us,
Yes,
please.
yes.
This low blood pressure,
Yes.
water,
Yes.
heart,
Yes.
etc., etc.
Yes, exactly. Yeah. So there are two ways of looking at low blood pressure. There are people who are walking around normally. They're not impeded in their daily activities at all. Then you measure their blood pressure and it's rather low. And it could be for a couple of reasons. Maybe they're just fit. So athletes, if you go measure Eliud Kipchoge's BP, it's probably on the lower side. So, but he's able to do everything he needs to do. But then there are those for whom they actually have symptoms, and the commonest circumstance and where this could happen, for example, is if somebody has lost a lot of blood, whether it's from a road traffic accident or they've gone to surgery, or they're dehydrated. We're talking about volume. Yeah. So if there's been a sudden loss in volume, blood volume especially, or dehydration from excessive sweating, then there's a relationship between volume and pressure. So if the volume goes down, blood pressure also goes down, and these people typically will have symptoms. You start feeling dizzy, unable to rise from a sitting position to a standing position. They can't walk as far, and so that would be low blood pressure, and there are ways to deal with it. If it was due to blood loss, of course you need to stop the blood loss, and you might need to transfuse some blood, or you might need to give them intravenous fluids in that situation. Yeah.
What treatment methods, I mean, along with research, some of the factors you said, okay, still unable to find out, but what treatment methods then are being used for the 10% of those who've sought care in rural communities? What treatment are they on? In terms of then being able to find it and its affordability?
Yes. So there are many challenges. The treatments that are available, you first start with lifestyle modifications, because those are the easiest, cheapest, most sustainable methods. So reducing salt in the diet, modifying the diet appropriately so that it doesn't cause obesity, exercise, and reduction in alcohol intake, reducing smoking. All this will play a large role in controlling hypertension. Then on top of that, if those don't work, then you introduce medications, and there are a couple of medications medications. I won't go into the names, but the medications that are there. But as you rightly point out, there are multiple challenges, starting with awareness, then there are challenges within the health system. So, for example, availability of the medications. People might be willing to take the medications, but they go to the health centers and the dispensaries and they don't find the medications there for multiple reasons. Or they might find the medications, but they're too expensive. Or they can afford the medications, but they can't stand some of the side effects, for example. So all of these factors play a role in the dismal numbers we're seeing of people who have their BP and their blood pressure under control.
Would you take this? I mean, would you take this until the symptoms, improve, as it were, or are we talking about lifetime treatment?
So generally, it's lifetime. So there are few people who have what we call secondary hypertension, which is you have a clear trigger or precipitating factor. So they could have been having kidney disease. You treat that kidney disease and their blood pressure settles. But for the majority of people, or they have thyroid disease and other illnesses. But for the majority of people, once they're diagnosed with hypertension, then the measures to control hypertension, including medication, are things that they need to follow through for life. And this is in the absence of symptoms, remember, because we said the symptoms only come when you're getting your stroke, but you're taking the medications to prevent you from getting that stroke or that heart attack or your heart failing. Yeah.
Someone is asking, what are the side effects of those different treatments?
Yes.
Those ones.
Okay. So there's a joke that my friend, a colleague of mine, frequently gives, that the biggest side effect is becoming broke. Yeah, because the cost.
It's expensive.
It's expensive, yes. He puts it in a better way. I hope I'll remember. But yeah, so expense is a major one. Yeah. But in terms of the common side effects, they can cause some dizziness. Some of them, they work by, we've talked about volume. So if you've got excessive blood volume, that can raise your blood pressure. So some of the drugs work to reduce your blood volume by making you urinate a little more frequently. So and that can interfere with your sleep. You've got to wake up 2-3 times to go to the loo. So that's a common side effect. Then a couple of others which vary. For example, some men might complain that it can cause some of the medications might cause impotence, for example. Others, for women, there's some of the medications for hypertension can, if they do get pregnant, can cause problems with the babies, for example. Yeah. So, but in the majority of cases, many of these side effects are generally mild, and the benefits far outweigh the benefits of taking the medications far outweigh the side effects. Yeah.
If one is on blood pressure, hypertension medication, is it possible for them to get to a point where they no longer need to take the medication? Can they be weaned out of the medication?
Quite possible, especially if they take the lifestyle interventions seriously. So typically what could happen is, with time, you notice that somebody has taken the lifestyle medications seriously. They've reduced the salt intake, they're exercising, they've improved on their diet. So you can tinker and titrate with the medications, and then but it doesn't often happen, but there are some people, yes, after doing all of the lifestyle medications, they do get off lifestyle modifications, they do get off the drugs. Yeah.
Someone says that they went for an operation, and after the surgery they developed hypertension. And they're wondering why.
Yeah, so that's a difficult question to answer, because I don't know what kind of operation he or she underwent. We don't know whether the hypertension was on its way coming anyway, and the fact that they went for the operation just provided an opportunity for monitoring so that their BP was measured, and then they discovered now that they have hypertension. Yes, but that said, what I would recommend is that perhaps discuss with the healthcare provider and try and understand what could have happened, and also importantly, even after understanding what could have happened, they do need to take measures to control their hypertension. Yeah.
You know, whenever one talks of hypertension, anecdotally people then think of lifestyle. Now, we are talking about hypertension in the rural areas. I think you've said this, but I'd just like to go over it again. Beyond poverty and the problems that bedevil people in the rural areas, what is it about their lifestyle that would predicate them towards having these numbers that we're talking of? And again, when you bear in mind that healthcare seeking behavior among most of the people in this country, especially among men, it has to do that death threat. Otherwise, one is very, very unlikely to go to a health facility where something like your blood pressure can be monitored. So what is it?
Yeah. So in rural areas, we're still studying, but we can hypothesize. We think there are a couple of factors that could be contributing. One is salt. So as people, you all know, salt is really cheap. Yeah, people complain about cost of living increasing, but you rarely hear people complaining that they're too poor to afford salt. So, and in rural areas, salt is used quite a bit, both as a condiment, you add it to the food, but also as a preservative for food. And all this eventually gets into the body and raises people's blood pressure. Then another factor that we think that could be contributing within the rural areas, it's still a bit hypothetical. There are a few studies we've done that suggest that it is true. Some of the infections that are prevalent in rural areas, for example, malaria, bacterial infections, can affect your blood vessels. Some of them can affect the kidneys, so you'll recover from the malaria or whichever infection it is, but you've got scarring. Some scars remain within either your blood vessels or the kidneys and other places, and this can predispose you to getting hypertension in future. Yes.
There's another question here, actually quite a couple. What role is the government healthcare system playing in easing the burden of hypertension management and treatment costs in the low and middle income majority?
Yeah, so quite a number of efforts and initiatives are underway within the government. There is an increasing recognition that a community-based strategy is necessary in order to control hypertension. So I'm aware that there are discussions about facilitating community health workers across the country. Right now, they're known as community health volunteers because they're not paid. But there's a community health worker policy that the Ministry of Health has developed and is hoping to implement, which will strengthen the community health system. And once that is strengthened, because you've got these people who are in direct contact at the primary healthcare level with the community, then they'll be better able to identify people with hypertension, so that this issue of people not being aware that they have hypertension because they've never had their blood pressure measured will have lower, that problem will be dealt with, and then hopefully they'll also be better able to refer these people to facilities where they can be taken care of. There are a couple of other policies that I'm aware the government and the Ministry of Health are reviewing, especially with regard to the availability of blood pressure medications within facilities. There are some policies, for example, that specify some medications can't be found in a dispensary. They only can be found in a level 6 hospital, but these are being reviewed so as to be in improve access to the medication. So those are just a couple of some of the measures that the government is doing to try and control hypertension. Yeah.
You know, sorry, Eric, you want to ask something?
I just wanted to ask a question here from social media, from the Diabetes Management Medical Center. They're saying, what's the relationship between hypertension and diabetes? Mm-hmm. They see so many people in the support groups with the same conditions.
Mm-hmm. Yes, so it's a two-way relationship in that the risk factors, many of the risk factors for hypertension are also risk factors for diabetes. So if someone is obese, they're likely to become hypertensive, and they're also likely to get diabetes. Then if someone has diabetes, diabetes also affects several organs in the body, especially the kidney. And there is a very clear relationship between the kidney and blood pressure, because the kidney, in simple terms, produces urine, which regulates blood volume. And if you've got your kidneys failing, then that can cause your blood pressure to rise. Yeah, so there's a two-way relationship. The risk factors they've got shared risk factors, and one can cause the other.
As a researcher, when you look at some of the causes and you look at some of the reasons behind hypertension, I'm sure you also think of ways in which these things can be mitigated against. Now, what has your research findings directed you towards when it comes to reducing these incidences and ensuring that the numbers not just stay down, but they reduce significantly? One. Two, how does one then, what would the research findings help you in finding a pathway to which one can detect these conditions at an earlier stage?
Yeah, so even though we talked about, and I mentioned that there are some factors which we don't know about that could be contributing to hypertension, we do know quite a lot about hypertension, and we definitely know enough to be able to control it. The problem is we are not implementing this knowledge appropriately. So it's more of systematic issues that need to be addressed. We shouldn't be in a situation where, as you say, someone only gets their blood pressure measured under the threat of death. Yeah, so if it becomes a normal activity, preferably maybe through community health workers who could be measuring blood pressure for people at their homes, then we'll be better able to detect these people who have hypertension. Then improving the health facilities in terms of making sure they have enough equipment to measure blood pressure. There's simple things you'll be surprised that are a problem in many of the facilities. So the devices that are currently in use are electronic. They require batteries. Yeah, so you find batteries have run out. In order to buy the battery, you need authority to incur expenditure and the whole administrative process. So the more hurdles you put, the less likely for that blood pressure to be measured, the less likely for someone to start treatment. So it's an entire cascade from detection of blood pressure, referral to the health facility, somebody taking their medication, someone understanding that you need to take this medication even though you're not feeling any symptoms, but we're assuming that this person you're telling to take the medication can afford the medication, which is not necessarily true. As health workers, we perhaps fail in trying to explain some of the side effects that are to be expected, and some people then become susceptible to myths that are out there about the side effects and therefore stop taking the medications. So it's an entire cascade along that unfortunately now leads to the increased burden of strokes and heart failure, heart attacks that we see due to poor control of hypertension.
So basically what you have said is it's a public health concern in Kenya.
It is.
And therefore it needs better addressing from policy to programmatic implementation. And that will come at the public health level. First of all, better testing so that you improve in the rural areas from 10% to as close to 100% as possible. And in the urban areas, from 25% to as close as to 100% as possible. That is access.
Yes.
And encouraging people to have this habit of just going to check. Okay. And then after you have been found to be hypertensive, access to the treatment. Affordable treatment. Okay. This is money. Okay. Thank you. The message is home.
Thank you very much. Thank you very much.
Dr. Anthony Etyang is a doctor and head of epidemiology and demography at the KEMRI Wellcome Trust Research Program. He's been here with us this morning talking about improving hypertension control in rural sub-Saharan Africa. We've learned quite a bit of this, and yes, we know that this needs to be addressed, but let's do what we can. And this is just presenting yourself to a health facility and saying, let's do the tests, right? And it's that one of just wrapping the thing on your arm, they pump, and then they tell you, one whatever over one whatever. Uko sawa. Or we need to have another
I
conversation.
hope it's not over one something.
Yeah.